Alrighty, everybody, welcome back. Got a really fun EKG here for you guys. So let's just do what we always do. Let's take a look at the trees. I'm gonna look at lead 2. I'm gonna see I've got these narrow QRSs that appear to be quite regular, marching along. They're narrow, and they all have P waves associated with them. And so let's start ahead and go through our algorithm. Let's look at the atria, what the atria is doing. I see I've got P waves in lead 1 that are upright, P waves in AVF that are upright. So I know that means my AV or my atrial conduction is going down to the left, which means good. That's a sinus P wave. Our rate is somewhere, let's find solid line QRS, 300, 150, 100, 75, 60. This is probably 65 beats per minute, which is in line with how the sinus node typically behaves. So now that we've evaluated our atrial conduction, let's take a look at what our AV node's doing. That occurs in setting of, or in the PR interval. Our PR interval here is normal. It is less than 200 milliseconds. So it's a normal AV node function. Make sure that that PR interval stays the same throughout, which it does. I don't see any P waves that do not conduct to QRSs. That's important to make sure that our AV node is conducting every signal that it gets. So the next thing I'm going to do is take a look at our QRS. We have a narrow QRS that tells me that it's taking the normal His-Purkinje system for rapid QRS depolarization. Our QRS is upright in lead 1. I would say it's almost isoelectric in AVF. So hard to say exactly what the axis would be, but if you look, we see that it's also upright in AVL. It's upright in lead 2. So we know that the axis is lead 2 is going down to the left. AVL is going up and to the left. AVL. So you know that it's somewhere along this leftward axis. So maybe a little bit of leftward axis with it being negative in lead 3. So that's okay. Next thing we're going to do is take a look at our ST, and as you probably already noticed, we've got some significant inferior and lateral ischemic changes. So if we look at our inferior leads, lead 2, we've got some significant ST elevation with these hyperacute T waves, which have a lot of area under the curve. Same thing in AVF, we've got these very hyperacute T waves. And we also see some elevation in the high lateral leads. Over here in V5, V6 as well, we've got some elevation. And so far I see some inferolateral ST elevation, right? Because those are the distribution of those leads. And so what I need to look for is, do I see ST depression that is reciprocal? So you just like to see reciprocal changes. I do see a little bit of depression in AVR, so that's a good reciprocal change. But when I look at the anterior leads, V1, especially V2, V3, see significant depression. And so every time you see depression in V2, V3, these anterior leads, the first thing I want you to think about is this also representing posterior infarct? And the reason why I say is this representing posterior infarct, because if I take a look at the lead placement of those anterior leads, those here, V2, V3, are measuring anterior forces. And so anytime we see negative changes, we should think, well, maybe that's actually measuring posterior ST elevation. And how can we check for that? So anytime we see this major anterior lead depression, we should think, I wonder if something's going on in the posterior portion of the myocardium. So the best thing you can do to check is we can do something where you take V4, V5, V6, and you actually place them on the back. And what you're going to create is a V7, V8, V9, what you're doing is you're just displacing these stickers in this fashion, and you get an EKG. And so if there is posterior ischemia, you'll see elevation in those leads when you place them posteriorly, because that should read the exact opposite of V2, V3. And so that's exactly what we did. We placed V4, V5, and V6, those stickers on the back. And look what we see. We see significant ST elevation, significant ST elevation, significant ST elevation. And so this is, we already said that we have inferolateral ST elevation, which is evidenced by our inferior leads, which is lead 2, Navy F, lateral with 1 here, and the V5, V6 that we saw in the other leads. But now we have posterior, evidence of posterior extension of that ST elevation. Another good way you can think of it, if we go back to our original EKG, you take a look at that deep, deep depression that we noted. And we said, hey, depression on the anterior leads might actually be elevation posteriorly. So what you can do is you can actually flip the EKG upside down and hold up to the light, what that would look like. So I've zoomed in here on V2, and if you flip V2 around, this is the normal V2 with that depression. But if you actually flip it upside down here, you see significant elevation. So that's if you're looking at it from the other side. So ultimately, what is this EKG? We've got a sinus rhythm. We've got inferolateral ST elevation with posterior extension. So this person is having an acute infarction, and yeah, I hope this helps, and have a good day.